دلوقتي هنقدم أستاذ الدكتور مؤمن لطفي داس كارديولوجي كلية الطب جامعة الوادي الجديد انتي اوبستي ميديكيشنز.
السلام عليكم ورحمة الله وبركاته. الشرف ليا طبعا ان اكون النهارده موجود في جامعة اسيوط. انا خريج 3 سنين الاولانيين من كلية الطب بتاعتي كانت في اسيوط. بعد كده رحت سوهاج، ومن سوهاج رحت عين شمس، خدت ماستر كارديولوجي من عين شمس، وبعد كده MD كارديولوجي عين شمس، وبعد كده حاليا في جامعة الوادي. فانا سعيد جدا ان انا ارجع تاني النهارده واكون موجود في اسيوط، وشكرا لحضراتكم على الدعوة الكريمة. هنتكلم النهارده على الانتي اوبيزيتي medication and its cardiovascular outcome. First, what is the cause of obesity? Obesity is an imbalance between calories in and calories out in the form of carbohydrate, protein, fat, and also healthy diet, physical exercise, and resting metabolism. However, it is not so simple like this, because obesity is a multifactorial disease. About 5% of obesity is syndromic, and 95% is non-syndromic obesity, and this is a multifactorial cause. Which is a multifactorial. First, we have to know the impact of obesity over the economic and over the health. The economic impact, this is the World Obesity Atlas published in 2023. By year of 2035, the economic impact of obesity over world will be about $4.3 million, trillion over the world. And approximately 1 in 4 people will be obese. And the economic impact on the low and middle income countries will be about $370 billion per year. As regards Egypt, by this date, 2035, approximately increase in obesity by 50%, and the annual increase per adult will be 2% per year, and child obesity 3.6% increase per year. And this will affect the economic impact on Egypt as follows: will be increased from $1.1 million to $2.22 per year, and affect the total economic impact and cost from $8 million to approximately $20 per year. And this will affect the national income of Egypt by 3% per year. The body mass index classification of obesity: obese patient whose body mass index above 30, and from 30 to 34 will be obese with moderate risk, and class 2 obesity from 35 to 39 point will be moderate risk or severe risk, and class 3 obesity has a very severe risk of cardiometabolic complications. Impact on the health: obesity almost affecting through mechanical stress. This will result into affection over kidney, resulting into hypertension, pulmonary hypertension, also affecting joints, respiratory system, resulting into obstructive sleep apnea, osteoarthritis, and also affecting liver disease. And all of this will result into increased lipolysis, increase in free fatty acids oxidation, and increase of lipid metabolism, and increase resulting in dyslipidemia, and this will result into type 2 diabetes mellitus, and non-alcoholic fatty liver disease, resulting into liver cirrhosis, coronary artery disease, and finally all of this will result into heart failure, resulting into coronary artery disease, stroke, and chronic renal failure. Every physician in every specialty has to deal with obesity, and almost this resulting to frustration to the doctors. Why cardiologists face several challenges in the management of body weight or obesity? Several reasons. The first one is the cardiovascular guidelines. The cardiovascular guidelines almost always recognize the importance of weight loss, however, focus on lifestyle modification only, and few details about the data outcome regardless to the obesity pharmacotherapy and obesity and surgery. Not to consider obesity as a therapeutic target because there is non-effective pharmacological intervention to be considered. There is lack of expertise or resources to implement the lifestyle intervention and limited familiarity to obesity pharmacotherapy, and also the cardiovascular outcome data to pharmacotherapy is limited. However, recently, guidelines 2023 over the management of cardiovascular disease with diabetes move the management of obesity forward with class 2A recommendation for use of glucose-lowering drug therapy for weight loss, and also recommending class 2 bariatric surgery. How we manage obesity? Almost we said diet and exercise, exercise and diet. However, this is mantra of diet and exercise almost always fail and resulting into modest effect on loss of body weight. Therefore, all of us, we need a drug which will maintain lifestyle and diet changes to maintain weight loss. Therefore, the management not simply loss of weight, not simply exercise. Why? Because obesity is a heterogeneous disease resulting into variable response to anti-obesity medication. It is chronic disease like hypertension, like diabetes, require lifelong treatment, and there is no cure. And also, it is a complex disease, require combination therapy, almost always needed. Who is the responder to obesity treatment? Responders who lose at least 5% of the body weight after 3 months of surgery, and those who must continue in treatment. Non-responders who would not achieve these targets and requiring to change treatment of the obesity. Obesity treatment will be highly effective if the patient loses more than from 10 to 20% of the body weight. There is no cure for obesity like hypertension, like diabetes. Withdrawal of drug therapy will resulting into relapse. Therefore, obesity is a chronic and relapsing disease and requiring a drug which increase satiety and inhibit hunger or increase catabolism. FDA approved many medications for syndromic and non-syndromic obesity. However, little of these drugs have cardiovascular outcome. Mechanism of action of anti-obesity medication mainly acting either central or peripheral or both. One of the most important drugs is GLP receptor antagonist, acting both central and peripheral through a mechanism in the brain and hypothalamus, and also through the GIT tract, and also dual receptor agonists such as gastro-inhibitory peptide and GLP-1 dual agonist acting both central and peripheral. Other medications like orlistat acting through the GIT tract, and some central acting drugs such as naltrexone and phentermine and topiramate acting only central. GLP receptor antagonist targeting incretin hormone. Incretin hormone, this is a specialized hormone present in enteroendocrine cells at different gut levels and respond to food intake, leading to stimulation of insulin secretions. GLP is the main member of this incretin hormone, resulting into stimulate insulin secretion by binding with these receptors on pancreatic beta cells and resulting in glucose regulation by suppressing food intake and delaying stomach empty, and therefore resulting into weight loss in the long term. This graph representing a cardiovascular outcome of various medication, all anti-obesity medication resulting in reduction of the systolic blood pressure, diastolic blood pressure, and LDL, with exception of centrally acting naltrexone and propion, resulting into increased systolic blood pressure and diastolic blood pressure. Therefore, they are contraindicated in patients with hypertension. As regard to evidence for GLP for reduction of cardiovascular outcome, liraglutide resulting into reduction with body weight. However, there is no data about cardiovascular outcome or reduction of the MACE, and also new drugs combination, which is known as tirzepatide, resulting into a reduction of the body weight by about 20%. However, there is current trials available, and the result on the cardiovascular outcome, and the result will be released at 2027. The only one GLP agonist now known to have a reduction for cardiovascular outcome or reduction of the MACE by about 20% is semaglutide. Semaglutide, which is known in Egypt by Ozempic, and by dose 2.4 milligram subcutaneous injection. These all the drugs at the time of approval by FDA. The first one is orlistat, and this is the side effect of orlistat and contraindication. All of the drugs are contraindicated during pregnancy. And this is centrally acting phentermine and topromine and naltrexone. And this is GLP-1 liraglutide, which is approved by 2014, and GLP-1 analog. However, we have be cautious, as this drug may resulting into increase the heart rate and resulting into hypoglycemia, and this semaglutide, and finally a combination tirzepatide, and all of these drugs, GLP-1, will resulting into, we have to be cautious in patients with family history or personal history with medullary thyroid cancer and men type 2. As regards semaglutide, selected trial, one of the most important trials, resulting that semaglutide at a dose of 2.4 milligrams subcutaneously once weekly and followed up for about 33 months, resulting into 15% reduction of the body weight among patients with overweight obesity, however, not have diabetes. And also there was reduction 20% in the MACE during the mean exposure of period of 33 months. This is liraglutide, or known as Saxenda, first approved in 2010 by name of Victoza for management of patients of diabetes, and now it is used for body weight, for reduction of the weight with body mass index 30 or higher, or 27 or higher body mass index associated with at least one of other comorbidity. This is semaglutide. And finally, this is tirzepatide, and this is the SURMOUNT trial of cardiovascular outcome and its importance. And there are several trials for its effect on reduction of the body weight and its effect on reduction of the MACE. What is suggested algorithm for management of obesity? We have asked the following question: what is the evidence of the weight and the cardiometabolic effect? Whether the beneficial effect is direct to the medication per se or secondary to total body weight reduction, هل patient profile types and medication efficacy and safety data. Therefore, a multidisciplinary team requiring lifestyle changes, behavioral changes, and pharmacotherapy and or bariatric therapy, and also review a patient medication, and all of this should be individualized because one size doesn't fit at all. This is an example of the drug which may result into increase the body weight, whether anti-diabetic treatment, anti-psychotic treatment, antidepressant treatment, and anticonvulsant treatment, and finally a steroid hormone, whether it is corticosteroid or hormonal replacement therapy. This is the suggested algorithm. We have to examine the body, patient age, and associated comorbidities. If the age is less than 65 and there is no comorbidities, any drug can be given. However, if the patient above 65, we can use liraglutide, semaglutide, or centrally acting drugs. However, if there is a comorbidities, particularly cardiovascular disease and diabetes, liraglutide and orlistat, semaglutide can be used. And also, if there is controlled, uncontrolled tachycardia, we can use also liraglutide, orlistat, and semaglutide. With depression, we can use liraglutide. Semaglutide not used because there was suicidal incidents. And orlistat also may be used in patients with history of medullary thyroid cancer or pancreatitis. Liraglutide, semaglutide are contraindicated, and only we can use naltrexone, paprione, orlistat, and centrally acting drugs. Therefore, to take home message, obesity should be considered as a chronic relapsing disease and should be treated. The choice of anti-obesity medication on the patient clinical profile, comorbidities, and drug contraindication. The effect of currently available weight loss monotherapy is still modest, with exception of GLP-1 receptor agonist. The subcutaneous semaglutide may have an expanded role in secondary cardiovascular prevention in patients without diabetes mellitus and overweight or obesity. The combination of more than one molecule may be needed to achieve a larger total body mass. For instance, tirzepatide and GLP-1 GIP dual agonist will result into approximately 25% weight loss with the highest dose. Thank you.
شكرا جزيلا دكتور على المحاضرة الجميلة بصراحة، يعني concise وconclusive يعني. شكرا جزيلا.
احنا بنشكر السادة الأفاضل زملاتنا وحبايبنا من جامعة الوادي الجديد، ويسعدنا ان احنا نكرم الأستاذ الدكتور محمد خلف والأستاذ الدكتور محمد فاروق والأستاذ الدكتور مؤمن لطفي.